Good afternoon. My name is Trevor. This is the PowerPoint presentation for the Research Perspectives Project completed for MSNC 5311 at Lamar University. So my introduction to this is all of us well know that healthcare costs are a high priority issue. Costs are on the rise across America for the past many years. And however, their insurance companies and CMS are reimbursing less and less for each thing. This is forcing facilities to do more with less effectively, run more efficiently. When they're looking at their budget, staffing is a huge portion of that budget, and running that staff to a level that's efficient to the numbers can cause some inappropriate staffing or understaffing in these areas, with obvious effects on patient care following that. A little bit more specific, staffing needs in a cardiovascular CICU are a little bit unique. These units aren't in every hospital, and some administrators may not understand what needs to be going on with these units. Like I said, it's a high acuity population. These people are very sick and can be very sick, and things change very rapidly. We also do many open heart surgeries, vascular surgeries, and these patients don't go to the PACU. They come up straight from the OR to the ICU. So it's kind of a mix between a PACU and a long-term ICU. So the staff has to be trained in both ways, and you have to have a lot of really highly trained staff necessary to take care of these patients appropriately with their needs. The purpose of the study that I'm proposing would be to study the direct effects of staffing these patients and their adverse events, if they have any, while they are in the hospital. Studies specific to the adult cardiothoracic surgery population are limited. A lot of studies out there based on general hospital population or hospitals as a goal, as a whole. But the adult population for these open heart surgeries and staffing is not very well studied. What I'm proposing would be to see if one-to-one staffing for these immediate post-op patients versus pairing them with another patient, stable patient, has an effect on adverse events. Currently at the CVICU at Herman, all these thoracic cases, depending on the OR course, are paired with a stable ICU patient or IMU patient. The study of this has not been documented to see if one-to-one care for these patients for the first 24 hours has an effect on their outcome would be beneficial. I just defined an adverse effect in this population as obviously cardiac arrest or death, take back to the OR within 24 hours, reintubation of these patients once extubated, blood and medication errors, or in the case of our TAAAs, paraplegia in these patients. The proposed sample I'm doing this study over would be the Memorial Hermann CVICU patient population in the TMC, Texas Medical Center. These would be elective thoracic cases over a period of 3 months. The design for this study would be a pilot study and then data review after the pilot. What I'm proposing is to staff these cases one-to-one for the first 24 hours. These cases include CABG or coronary artery bypass grafting, either on or off pump, any kind of valve surgery, repair or replacement, and TAAAs or thoracoabdominal aortic aneurysm repairs, which we conduct here at TMC. Included will be only non-emergent cases, and if the patients are unable to be staffed at a 1-to-1 for the first 24 hours, they will be still included in the study, but they will be compared as obviously not soloed for nursing care. Data collection would be collected by the use of our charge nurses. They would be doing like a one-page worksheet with limited data on nurse staffing for the first 24 hours, what kind of surgery they had, and any immediate postoperative adverse events. They could put this in a collection box on the unit. Researcher would follow up this data at least once a week and follow up through these cases and see what kind of adverse events, if any, these patients are having until discharge. Gold number, based on 3 months and elective cases at the Memorial Harmon CV ICU, 200 pump cases would be roughly appropriate for this kind of data collection. Direct implications of this study, first and foremost, include patient outcomes. If this data shows that improved patient outcomes are accomplished by staffing these patients 1-to-1 for the first 24 hours, we have tangible evidence to show that more staff is appropriate. Also, further analysis could show that what healthcare costs are, and if you break it down, showing healthcare costs for patient nursing hour for staffing for this 1-to-1 staffing versus what it would cost to treat these adverse effects could be used for evidence to show that increased staffing is necessary and actually cost effective in this population. And lastly, for our surgeons, their STS data would be positively affected, hopefully. This would improve their statistics and improve their overall, what you kind of call scorecard. Limited number of reintubations or extended intubations, post-op infections, etc. And if we could show that this improves their numbers, we could have another fire in the ring type thing for us to have better staffing. Lastly, if there's any questions or concerns about this study, please feel free to post them. They are welcome. Suggestions are also very welcome. This is an evolving process, and making this the best that we could is the ultimate goal. So thank you for watching. Have a good day.